And I rearranged the stuff, and I did this last year too. I just forgot to put it on the syllabus because we talk about anticoag during both AFib and, well, antiarrhythmics in general, and we also will talk about it during acute coronary syndrome, so it makes more sense to do it now. But basically, we have a number of ways that we can prevent the formation of clots. So I like to break it down in an overly simplified way of red clots and white clots, which just probably makes most people who do this scientifically cringe, but here it goes anyway. So you have red clots, which essentially are things that involve red blood cells and are fibrin rich. This is basically blood pooling. So when we talk about drugs as anticoagulants, they're working on these types of clots. These are going to be like venous thromboembolisms and, well, like stroke-related clots that are caused by atrial fibrillation. So anywhere blood's pooling, like in the fibrillating atria, in the lower extremities, where you might get a DVT, pulmonary vasculature. White clots would be platelet-rich, and these are going to be usually in arteries where blood is flowing quickly. So it's very unusual to get a red clot, like with red blood cells and fibrin-rich in arteries, because the blood usually doesn't pool unless you get a blockage, and then you get a buildup, and then that's where things get tricky. Then you get both. But a lot of thrombi will eventually have components of both. If you start to get a red blood cells clotting together, eventually you can get platelets to aggregate to, and it's all going to mix. And the same thing with a clot that's in the arteries as well. You're going to get a similar type of thing going on. So we treat them differently, but essentially a clot's going to look like this. This slide's a good tie-in from what we just talked about with cholesterol. So one of the reasons why having high cholesterol is bad is that you get plaque buildup in the arterial wall. So the plaque will build up in the artery, which restricts it, which can be problematic on its own. But over time, that plaque can actually break through the arterial wall and rupture, which causes inflammation. So platelets will aggregate immediately, and over time it decreases the blood flow to a point where you can get a much bigger thrombus, and then you can get total occlusion. And that's where you have the significant risk for a full-on heart attack at that point. So that's why if we can decrease the amount of LDL transporting cholesterol to these areas, we can hopefully decrease plaques. And actually there's some theory that statins not only do that, but they somehow stabilize the plaques too, so they're less likely to rupture. How that actually works, we don't really know. Statins have a lot of theoretical benefits beyond their cholesterol lowering obvious abilities. So we'll get into that next spring, but just to give you the 5-second synopsis, this is sort of why the last slide was important, because if we can prevent this from happening, we can prevent a lot of what we're going to talk about, especially during acute coronary syndrome, the next set of lectures. Okay, so platelets are recruited when you have some sort of compromised integrity of the vascular lining. They're going to get exposed to collagen fibrils, which gives a surface for adhesion, and then that triggers a downstream effect within the platelets. They'll signal and bring in other platelets to aggregate together. Ultimately, you have a couple of different pathways that the platelets use, and we can manipulate those pharmacologically. Platelets have about a 5-day life cycle, and the only reason I bring that up is because if you're holding any of these medications for surgery and you want them to be completely out of the system, you have to stop an antiplatelet agent for about 5 to 7 days to make sure the patient has enough time to rebuild their platelet supply. Otherwise, you could have a bleeding risk potentially. This just shows the different receptors on platelets. We're going to come back to this if you want the visual on how platelets aggregate and what I mean by GP2B or versus some of the other ones we're going to mention today. But I think the next slide, well, there's another slide that's a little bit better coming up that shows some of the receptors and how the drugs work on them. But there's 3 major classes that work on platelets and 2 that I really care about. Aspirin, so thromboxane A2 is produced by cyclooxygenase pathway, so similar to what we talked about with COX inhibition, lipoxygenase inhibition. It's all part of that, and aspirin inhibits that process. Thromboxane A2 is a component used for platelet aggregation. So that's how aspirin works to prevent platelets from adhering to each other. P2Y12 inhibitors are, or ADP inhibitors, prevent the interaction of, adenosine diphosphate or ADP with G protein coupled receptors. ultimately that prevents platelets from adhering together. So another mechanism. GP2A3B inhibitors inhibit a final common pathway of platelet leaking. These are more commonly used for catheterization procedures or acute things, and not necessarily like you're in the emergency department acute. I mean more like procedural related. We don't really use them outside of like our cath lab probably is where we see them the most. So they're more of a, we need this person inhibited now. We don't have time for aspirin or P2Y12 to absorb, so we have to give them something IV. Those drugs come IV, so that's why we do that. There is actually an IV P2Y12, otherwise they're all oral, so they do take oral onset into consideration. So that's the difference, really, but I'm not going to care about the GP drugs for this, because I think they've got a very niche role, and I'm not going to test you on them. There's a new class out there that I put a reference for. It was called Vorapaxar, that wasn't found to be beneficial and increased bleeding risk too, so it never got to market. In case you're wondering if there's other drugs out there. So as promised, here's a slide that shows you a little bit more about where the drugs work in a big green platelet cell. So you have a ton of different receptors and signaling pathways going on between platelets. And the only thing to remember is that the drugs work on different places. So you'll see people on aspirin and a P2Y12 inhibitor, like any of these three drugs listed here, or these drugs here. And what happens is that they work synergistically because they're covering two different angles of how platelets get together. And that's why we combine them. Sometimes we just use one or the other. It just depends on the indication. We'll cover that as we go through both this set of lectures, and then we come back to stroke and the neurology component next semester. Okay, aspirin is acetylsalicylic acid, or abbreviated ASA often. It inhibits activation via thromboxane A2 suppression. Usually, most patients, a baby aspirin, aka the 81 milligram, is going to be just fine. 325 is used a couple ways. So in acute phases, we'll use it as a loading dose. So if somebody comes in and they're having an active heart attack and they haven't taken aspirin yet today, they're going to get 325. But daily regimens, post-cardiac or post-heart attack, post-catheterization procedure, people are going to usually be on the 81. Every once in a while, somebody might be on a higher dose, like post-cabbage, but that's situational. So generally speaking, 81 is fine. You'll run into a lot of patients that just take a full-strength aspirin for no real reason. So I think if somebody's on an aspirin and there's not an indication, it's always a good discussion point for you as the provider to say, why are you taking this? Did somebody tell you to take this? Because it does increase your bleeding risk somewhat. And you're supposed to be on aspirin for a good reason. It probably is a benefit to being on it, other than you're going to make yourself bleed, which of course isn't a benefit. So the question is, like, who needs to be on aspirin and when? And there is some primary prevention that we can talk about, and we'll talk about that more during stroke. But for the most part, people aren't on aspirin unless they've had some sort of an incident. Okay, well, I guess primary prevention here. So if you're 10-year risk, talk about the Framingham/Omnibus/American Heart Calculator. If it's over 10% and you're over 50, that could be considered primary prevention. So they might give you an aspirin empirically to prevent a cardiac event. Pre and post ACS. So if you're having acute coronary syndrome, they're going to give it to you during or prior to whatever procedure they're giving you to relieve the acute coronary syndrome, and then post. We'll talk about anticoagulation a little bit more and how that fits in, and what if somebody's anticoagulated for an arrhythmia? Do you give them aspirin still? We'll talk about that a little bit later. And then stroke or transischemic attack, those are going to be aspirin candidates as well. Bleeding risk, aspirin at its low doses, especially the 81 milligram, it's highly unlikely to see a lot of bleeding with that. So it's relatively safe. In fact, I've seen a lot of patients who are high risk go through our ORs on aspirin without really any issue. They don't always hold aspirin, especially if you have like a high stroke risk. The risk of holding the aspirin might outweigh the benefit of, the possibility of bleeding, or the benefit of holding the aspirin, risk of bleeding. So there's, the question is how high risk is your patient, and what's your appetite for that risk? But generally speaking, bleeding risk is quite low. Aspirin is really toxic if you take a ton of it, but you have to take a lot of it. You probably have to attempt to do that intentionally. Usually you don't do that accidentally. But It is contraindicated in children less than 16. Not that you generally need it in kids less than 16, but the baby aspirin gets confusing. Don't use aspirin in kids. It causes this thing called Reye syndrome, which is an encephalopathy associated with a comorbid viral illness. Really rare, but can be fatal. So we don't use aspirin in kids or teenagers for the most part. And there's also a product that you might see that's not relevant for this test or this lecture, but it's a combination aspirin and dipyrimidol. Dipyrimidol is a separate type of antiplatelet drug that works synergistically, and it's for stroke prevention only. So it's only stroke. We'll talk about it more during neuro next semester. Yeah?
So you see a lot of people, I feel like, on aspirin. And you said, as long as there isn't these indicators, is there any research that shows that?
No, there's actually a study put out a while ago that, because I think for a while every diabetic patient was being put on aspirin, and they did a study showing that it actually wasn't beneficial. There wasn't any mortality benefit unless they met certain criteria, like their risk was really high or they were older. So younger diabetic patients don't need to be on aspirin. If they wanted to take it, patients can buy it over the counter, so certainly they might. And a lot of times I see that where people come into the hospital and they're just taking it and they don't necessarily have an indication for it. It's relatively safe. There's not a lot of risk with it, but it does, increase your bleeding risk somewhat. So if you've got an accident or something, that could be a problem. Okay, P2Y12 inhibitors. First of these is the oldest one and the most common one. It's Plavix or clopidogrel. So a couple different ways you can use clopidogrel. You can load it in an acute situation using a big dose, or you can do maintenance dosing. Clopidogrel is the preferred agent post-ACS for maintenance because it's inexpensive and it's fairly effective. There are some problems with it. So we talked about this. You probably don't remember this example, or maybe you do. Good for you if you do. But I talked about this when I mentioned prodrugs at the beginning of the year. So prodrug that gets metabolized into its active form, clopidogrel is one of those. So if you have a genetic polymorphism that makes it so your body doesn't make a whole lot of CYP2C19 or 3A4, you aren't going to get a lot of benefit from Plavix. And sometimes we've seen people not do clinically all that well on Plavix because of these reasons. So this is actually one of the few areas in medicine where pharmacogenomics is heavily applied. And by that we mean that you can screen for these polymorphisms. And so you can see how well somebody's going to respond to Plavix. It's a couple $100 to do a test, but in the long run it's hugely beneficial. So if you can screen this out, if the screen's negative, give them Plavix. It's cheap, it's effective, it's great. If not, we're going to try something different. So that's basically the gist of it, but most patients will be on Plavix. And the polymorphisms, they tend to be ethnic specific, but not always. So like, for example, sometimes Asian patients tend to have lower expressions of these particular enzymes, and Caucasian patients tend to maybe have higher expressions, but it's not an absolute. So people are still tested. I'm not sure if they do it routinely, but I believe in a lot of cases they are doing that now. Proton pump interactions. This was an interesting controversy that I'll talk about very briefly. So this is something you might hear come up. Proton pump interactions suppress, or proton pump inhibitors suppress stomach acid production, so they're Nexium, Protonix, Prilosec, etc. All your common over-the-counter heartburn medications. And what happens is that these inhibit one of the enzymes mildly, I think it's 2C19, to prevent conversion. And so there's this big scare several years ago where like, oh, we're giving everybody PPIs and we're also giving them Plavix, and it's not allowing it to convert into its active form, and so everyone's subtherapeutic on Plavix. Well, they did some studies and found that people clinically are probably doing fine, even though it does seem to actually affect Plavix's efficacy. So, well, Plavix's potency, I should say. So Plavix doesn't inhibit platelets to the degree it would if you aren't taking a drug, but clinically people seem to do okay with it. So for the most part, we ignore that interaction. But if you see that flag, just know that that was kind of a big deal for a while, and sort of we switched everybody from PPIs to histamine 2 antagonists, which don't have the interaction. And you could do that for safety reasons if you were concerned. But yeah, it's sort of been clinically negated at this point, I guess. I don't know. I don't buy it 100% that it's not a big deal, but for the most part, people will still prescribe them together. Plavix has the lowest percentage of platelet inhibition out of all these three agents. Technically, it's the least potent. It has the lowest bleeding risk as well, which probably makes sense based on that above bullet point. But again, clinically, it's just as good as any of them. There's no real benefit over the other ones, except in the acute phase, which I'll talk about here in a second. And hugely important, generic and inexpensive. Prasugrel, not generic and not inexpensive. Prasugrel is sort of the oddball. It's probably the least popular one. You can do it in the acute phase by loading it during a heart attack, but maintenance would probably be the more common thing. And this is going to be also a prodrug. However, it's thought to be less prone to CYP pathways, so it's got more pathways where it can go through. So if you have a polymorphism that's making it so your body doesn't express one enzyme very well, but maybe you have others that work well, the drug can kind of work its way through multiple areas in the liver, which basically makes it less prone to those genetic issues. So it is considered an okay alternative for those patients with polymorphism. It's the longest lasting. It has a lot of active metabolites, which can be complicated because it also has the highest bleeding risk due to that. If you have a history of stroke or TIA, this drug is contraindicated because it increases bleeding risk and increases mortality. So that's one just problem with Prasugrel, is that the bleeding risk. So that's the one thing I'd remember out of the differences of these that is just specifically related to Prasugrel, is the bleeding risk is being higher. And then we have Ticagrelor, or Brilinta, which is the new one, or newest one. Brilinta is not a prodrug. It's got reversible binding. It's also useful for loading and maintenance. You'll notice it's a BID drug instead of Q-Day, which makes it less convenient for patients. It's also brand name, so it's more expensive. It's got some CYP3A4 metabolism, but not enough to be considered genetically problematic. It has the highest percentage of platelet inhibition, and it's an to the point where it can't be used with aspirin full strength. So that actually increases your bleeding risk substantially. One of the things that we like to use Ticagrelor for is in the acute phase, because there was actually a pretty decent study that showed it was superior for improving the outcomes of major cardiac events compared to clopidogrel. So the idea is that it is a higher percentage of platelet inhibition. It also has a faster oral onset and seems to take effect about 30 minutes quicker than Plavix does. So it's expensive, but the outcomes seem to pay for themselves. If you weren't in a hurry, so like for example, if you have an NSTEMI, which we'll get to, I'm getting ahead of myself a little bit, but an NSTEMI wouldn't be like necessarily something you need to take somebody to the cath lab immediately for. It might just be elevated troponins, and the patient has mild chest pain but doing okay. Maybe they're like, we'll schedule them into the cath lab tomorrow morning. You could do a loading dose of Plavix because time isn't an issue, and it's going to work just fine. In this case, when you're trying to get somebody who's having an active cardiac ischemic event to your cath lab within minutes, it's really important that you do everything as quickly as possible. So those 20-30 minutes, the difference between Plavix and Ticagrelor, do actually make a big difference. So that's why we've switched to Ticagrelor at Abbott exclusively for our acute phase for ACS. So that's the one we use. But maintenance-wise, rarely ever used, just because it's expensive and it's twice daily, and there's not a huge role for it there. And I talked about this a lot. This is just a slide comparing these. In case you want to get into more detail, read about the drug interactions, how long you hold the drug for, that type of stuff. But I'm not going to reiterate it at this point. And let's dig into this just a little bit, because I don't want to record a ton of lecture. As little as I can. All right, so switching gears. So we talked about platelets. Now let's talk about the clotting cascade. So when we talk about an anticoagulant, you're talking about something that interferes with the clotting cascade. And all anticoagulants generally have one thing in common. They're going to affect the common pathway at some point. So common pathway, this drawing shows it starting here, but really it starts with factor 10. And a drug that inhibits factor 10 or 2 or both is going to be considered a probably effective anticoagulant. So if you're remembering factors and inhibition, those two are the key. And we'll talk about there's some drugs directly targeted towards these that inhibit factor X or factor 10 specifically, or antithrombin agents that inhibit factor 2 specifically. And then there's drugs like heparin and warfarin that inhibit several different factors. But again, the commonality is that they all inhibit those central factors. They have to get there, otherwise they aren't effective. And that's reason is because you have to block both sides of the clotting cascade. So your intrinsic pathway, if you have some sort of a damaged surface like intravascular, maybe, that's what's going to be upregulated. Extrinsic pathway would be some sort of external trauma that's happening. Okay, so this is our red clot drugs, and there's a lot of different nuances to anticoagulation. But the goal is to prevent synthesis and activity of most active clotting factors. These drugs don't break down clots. All we're doing is preventing the body from increasing the size of the clot. And over time, the body will automatically break down that clot on its own. So like for like a DVT, you aren't giving the person anything that's going to break down that clot. You're just going to prevent that clot from getting bigger. There's a lot of products available. We have oral, IV, sub-Q. There's fast-acting ones, short-acting ones, and everything in between. And patients can have all types of reasons. The most common ones being venous thromboembolism, atrial fibrillation, stroke, acute coronary syndrome, possibly status post some surgeries, implant surgeries like orthosurgery. It's common to use some form of anticoagulation. And there's sometimes prophylaxis. So if somebody's immobile for a long period of time, they might put them on a low-dose anticoagulant for prophylaxis. One common thing with older anticoagulants is that the newer ones not so much, but the older ones require pretty frequent monitoring. So heparin and warfarin specifically require pretty intense monitoring to make sure we're not over anticoagulating somebody, because you can cause a bleed quite easily if you don't do this correctly. Okay, I'll start with heparin. So heparin potentiates antithrombin, which complexes with factor 10A to prevent the formation of thrombin. So it's really working on that factor 10 step, but preventing factor 2 from activating. It also inactivates a couple other factors as well, so it has a couple mechanisms under its belt there. It's a standard therapy for pretty much any condition that requires anticoagulation. You can use heparin for. Problem with heparin is it's only sub-Q or IV. So this isn't something you can easily, it's not easy to do a heparin one-to-one conversion to somebody for outpatient therapy. So at some point you have to bridge somebody from heparin to an oral drug to get them out of the hospital. And so that's its biggest challenge. But heparin's quite effective on its own, and it's really cheap, which makes it nice to use. Weight-based dosing, usually specific levels are targeted. We're monitoring with APTT or anti-10A activity. It depends on what institution you work at and what lab they use. But heparin's highly protocolized at most places, so we have a system where the provider puts in an order for heparin, nurse sees that order, they'll enter some parameters into a calculator, it tells them what dose to start at, how much of a initial bolus dose to get, and what continuous infusion to run the IV heparin at. And then it'll give them parameters, so it'll say check a level in 4 hours, or check a level in 8 hours. They'll check a level, plug in that level, computer tells them decrease your heparin dose or increase your heparin dose or keep your heparin dose the same. They get very protocolized. A lot of it's based on weight-based calculations, but as pharmacists, we kind of follow along with heparin. We don't really do much heparin dosing, but it's mostly just we're confirming what the nurse is entering is what ideally is calculating, and the calculator looks like it's thinking correctly. Heparin's very quick. It's basically immediate onset if IV, which is nice. It's a fast-acting anticoagulant. If you give a sub-Q injection, it's about 30 minutes. Half-life's about 1 to 2 hours. So if you overdo your heparin, you can not only reverse it with a drug called protamine, which we'll talk about, but it's not got a long half-life. So your bleeding risk is a lot lower than if you gave somebody like warfarin, which lasts several days in the body. And renal adjustment's not needed for heparin. So for your renal patients, this is a nice drug. Just a side note and fun fact, heparin's produced by extracting intestinal linings from pigs, and it's still actually done this way because it's cheap to do it that way. So from like industrial farming, operations, they'll actually use the byproducts of that for heparin production. Synthetic and other semi-synthetic options are extremely expensive to make heparin. So it's actually the cheapest way to do the natural product per se. And occasionally you might get patients who are totally vegan or really against pork products whatsoever for religious reasons or whatever it might be, and they might actually say, I can't do heparin at all. We've had that happen in the hospital occasionally. There are plenty of alternatives to heparin, but you just might know that that could be an issue. Generally speaking, it's not. This is just an example of how we dose heparin. I'm not going to test you on the weight-based dosing of heparin, but it's just, again, an example of how you might approach a patient. And this depends on the indication. So, for example, for a patient with a pulmonary embolism, we'll treat them differently than a patient with an acute coronary syndrome. The dosing and the evidence, the literature usually supports different rates of infusion just depending on how they did the studies. So we tend to follow those. And that's why you might see subtle differences between different indications in heparin. Heparin-induced thrombocytopenia is probably the most notorious side effect of heparin. other than just bleeding out. Of course, you could do that with any anticoagulant, but this is kind of an interesting side effect. So what happens is you get a precipitous drop in platelets about 50%, 5 to 19 days into therapy. You need to stop your heparin immediately, and you don't re-challenge for 100 days. It actually increases your chances of clotting. And the reason why is your body makes antibody complexes with the heparin, and it causes your platelets to immediately activate. So you think that decrease in platelet equals more risk for bleeding, but in this case, all your platelets are activating, so your risk for clotting increases substantially. And because of that, people can get ischemic areas like necrosis, like you can see in this really wonderful picture I found. You can also see, like worst case scenario, like fatal strokes, fatal MIs, things like that. It can be really problematic. So if somebody, you can't really predict this, it's going to happen. If it does happen, you just got to deal with it as best you can. But for the most part, if you do get these antibodies circulating, you can do tests. If somebody has a history of HIT, you can run a panel to see if they still have active antibodies. If they do, you probably wouldn't want to give them heparin. But generally speaking, the body will clear those antibodies after about 3 to 4 months. So after that, they theoretically are good to go on heparin again. And there's not a lot of evidence to say that they will react to that, interestingly enough. So it's sort of a freak thing that occurs, and no one really knows why. But just to keep you aware of it, because it is a big deal if it does happen. I'll finish up the heparin group, and then we'll be done. Low molecular weight heparins are similar in action to heparin, but it's just a smaller molecule. So heparin's, a natural product. It's kind of a big chunky molecule, and these are basically heparin but truncated to the most active chain of the heparin molecule. So they don't really have a high incidence of HIT. However, if you did have a patient who had active HIT, you would not give these agents because there is a slight risk of that. Mostly target factors 2 and 10, 2 and 10. Usually we don't have to do monitoring on these. They've got more predictable responses. So it's all mostly weight-based dosing. Peak onsets are predictable for most patients. They're renally eliminated. So somebody's kidneys are functioning relatively well. We can predict what type of dose is going to work best for that patient. So from an outpatient perspective, these are nice drugs because they're considered the bridge to some other therapies. So if you have somebody on heparin and you want them out of the hospital, but you don't have time to get them up to date on some oral medication, you can use these as a bridge in the meantime for a week or so until you get to that point. You can also use these inpatient. There's no reason why you couldn't. They're just expensive. Heparin's a lot cheaper, so that's the big reason why we don't use them. Yep.
Is this only injectable?
Yep, they're sub-Q injections. So I just mentioned bridging therapy. So warfarin, we'll talk about warfarin on the next set of slides here, and I'll actually record that part for you guys. But warfarin takes a while to get up to speed. So when you hear about bridging therapy with anticoagulation, a lot of times we're talking about low molecular weight heparin. And you want to keep the patient anticoagulated until that warfarin is fully therapeutic, and then you can get the other anticoagulant. There's really no risk in having both on board for a little bit. Your bleeding risk doesn't increase all that much. So if you overlap the therapeutic range a little bit, that's okay. Let's see. Again, you can substitute this for heparin in pretty much any situation. These have broad indications, but cost, because they come in pre-filled syringes, they're pretty expensive, even though they're generic, and they're just they're not used as often, just for that reason. But they are really convenient. Not as fast-acting as heparin. About 4 hours for onset. Titrating is impossible, basically, because you have 12-hour intervals. Once you've given somebody the drug, they're stuck with it for a while. Some people say not monitoring these is actually a con because you don't know how well it's working. What if somebody's not processing it the same as another person and they get overdosed? There's theoretical implications to that, but study-wise, we haven't really seen that pan out. And again, they're expensive. The common one you're going to see is this Lovenox or enoxaparin. Adulteparin is used, but it's not as common for whatever reason. Most people do Lovenox. And then reversal, I mentioned a drug called protamine. And all I want you to know is that protamine reverses heparin, and it combines with circulating heparin to form a neutral salt that can be eliminated. It takes about 5 minutes to work, so it's pretty fast. And 1 milligram of protamine neutralizes about 100 units of heparin, so that's how we dose it. Heparin, this can be tricky because it doesn't last very long, so if you have a lot of heparin on board, you could end up with a rebound possible about 8 to 18 hours after the dose, so you have to watch your patient pretty carefully. They have seen randomly sudden drops in blood pressure, and people aren't exactly sure why protamine causes that, but you could have a hypotensive emergency on your hands with a big dose of protamine. But what's worse, a severe bleeding episode or some hypotension. Hypotension is a lot easier to treat than a severe bleeding episode, so that's usually the lesser of two evils in those cases. And anaphylaxis reactions related to the infusion tend to be higher reported with protamine compared to your average IV drug. So it seems to be more antigenic for some reason. But again, you shouldn't have to use this all that often, but it is something that happens occasionally. And you'll see it used if you do procedural work where they're using heparin for short cases. They might want to reverse it with a little bit of protamine after the case is over. You see that done every once in a while for specific indications only. But for the most part, it's a situational thing. But it is nice to have a reversal agent for an anticoagulation or an anticoagulant. It's a nice safety net that you have at your disposal. Okay, so we'll stop there.